Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
In this video, we are covering infection pharmacology. We're covering a wide variety of drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. Before we dive in, let's review a general practice point. Unless doing so will significantly delay care, it is best practice to collect a culture and sensitivity from the patient prior to initiating antibiotic therapy. Usually, patients are started on a broad spectrum during the initial phase of care, with narrow-spectrum drugs replacing these if indicated based on the results of the CNS. Patient education for all antibiotics should emphasize the importance of taking the full course of the medication as prescribed in order to reduce risk for antibiotic resistance. First up are penicillins, including amoxicillin. These are broad-spectrum antibiotics and commonly prescribed to treat minor bacterial infections. However, many people report an allergy to penicillins, and so it is very important to verify patient allergies and types of reactions prior to administration. Also of note, if a patient is allergic to penicillins, they also may exhibit a cross-allergy with other classes of antibiotics, such as our cephalosporins, monobactams, and carbapenems. The nursing priority after administering penicillin is to monitor for a reaction. If the reaction is mild, characterized by slight urticaria, for example, antihistamines may be given. For more severe allergic reactions, such as anaphylaxis, epinephrine may be given to preserve the patient's airway. Commonly reported side effects include GI distress as the gut microbiome is impacted. Patients should be encouraged to take penicillin with food and increase intake of probiotic food sources to reduce this complication. Also important for patient education is that penicillin can reduce the efficacy of oral contraceptives, so a barrier method should be used. Connect the P's here. Penicillin can make you pregnant if you're only popping pills. Now on to another class, cephalosporins, such as cephalexin and ceftriaxone. Remember that an allergy to penicillins may mean that patients are sensitive to these medications as well. These meds are commonly given in the treatment of UTIs, with later generations of this class even indicated for the treatment of meningitis. There are some administration considerations to take note of here. Ceftriaxone is incompatible with lactated ringers and should only be given with normal saline. If given IV push, make sure to flush before and after with normal saline if the patient had been receiving LR previously. If this medication is given through IM injection, it may be diluted with lidocaine. This medication can burn when being given, so warn the patient of that possibility. A large muscle should be used for injection, not the deltoid. In patients with bleeding risk, third-generation cephalosporins have been known to increase INR and therefore increase risk of prolonged bleeding. Coagulation studies should be obtained and monitored for these patients, and vitamin K may be indicated to stimulate clotting abilities. A final point of consideration here is that patients should be instructed to avoid concurrent use of alcohol while on this medication. An unpleasant disulfiram-like reaction may occur if these substances are combined. The class monobactams includes the drug aztreonam. As mentioned before, sensitivity to penicillins may indicate that this patient will also be sensitive to this class. This medication may be given to treat aerobic bacterial infections, such as those present in the mucous membranes of the genitourinary and respiratory tract. Commonly reported complications include site irritation upon administration. Monitor closely for phlebitis if given IV, and if given IM, try to rotate sites and only inject into large muscles. Now for carbapenems, with the prototype imipenem. This is the final drug class we'll cover here that may be contraindicated if the patient reports a penicillin allergy. This medication is also broad spectrum, but may be reserved for serious infections only, due to the risk for some pretty nasty side effects. Among these is a risk for superinfections, as the normal microbiome is disrupted. This medication may also result in nephrotoxicity and hepatotoxicity, so patients at risk of these complications should have renal function and liver function monitored throughout the duration of therapy. If given IV, monitor closely for extravasation, and be prepared to administer a neutralizing agent if this occurs. IV infusions may need to be delivered slow to reduce the nausea and vomiting associated with more rapid administration. Now onto vancomycin, a high-yield medication on the NCLEX, so pay attention. If patients are allergic to penicillins, they may be able to tolerate this medication. Furthermore, vanco is indicated for the treatment of superinfections, such as MRSA, as well as for severe C. diff. There are several administration considerations with this medication, however. Serum levels must be adequate to fight infection, and so trough levels should be obtained prior to administration, and peak levels should be obtained when the drug is at its highest concentration during infusion. Vanco may need to be diluted and given slowly over 1 hour IV. Rapid administration is associated with the potentially severe complication of red man syndrome. If patients begin to exhibit diffuse erythema and exhibit tachycardia and hypotension, first try to slow the infusion rate to see if the condition will resolve. If these presentations persist, however, stop the infusion to prevent further damage. Vanco can also be very nephrotoxic and ototoxic, potentially conferring irreversible hearing changes if combined with other ototoxic medications such such as furosemide and aspirin. Dosage modifications may be indicated for patients with compromised renal function, and the adequacy of the kidneys should be assessed throughout therapy. Tetracycline antibiotics can be used to treat a variety of bacterial and mycobacterial infections, and is even indicated for the treatment of acne vulgaris. Like other antibiotics, some adverse effects include GI distress and risk for superinfections. Unique to this medication is the impacts it has on the dentition of children. Pregnant patients on this medication should avoid use and use barrier contraception. Exposure to tetracycline in utero can lead to growth suppression and abnormal coloration of the deciduous teeth. If given to children who have had their permanent teeth come in, their teeth may become permanently discolored as well. Tetracycline can also lead to photosensitivity, so patient education should emphasize using SPF and high coverage clothing when going outside. Remember this drug by thinking of a kid cycling, getting a sunburn, and with bugs staining his teeth as he runs into them on his bicycle ride. Now for macrolides, such as erythromycin. The most common way you'll see this medication given in practice is via ophthalmic ointment to neonates. This medication is used prophylactically to prevent the transmission of maternal gonorrhea during vaginal deliveries. Remember this special fact by connecting erythromycin with eyes. This medication can also be administered to treat infections when patients have allergies to penicillins. However, caution must be observed with patients who have cardiac complications, as systemic absorption could lead to fatal cardiac dysrhythmias. Furthermore, erythromycin can be potentially ototoxic and should not be combined with other ototoxic medications such as furosemide and aspirin. Gentamicin is an aminoglycoside antibiotic and may be given for severe ENT infections. If given via eye drop route, ensure that proper protocols are being used for administration. Drop the medication into the lower conjunctivae and press on the inner canthus to reduce systemic absorption. Systemic absorption could lead to complications such as ototoxicity and nephrotoxicity. Other ways to reduce risk of toxicity includes monitoring the peak and trough levels of this medication. Another administration point to consider is that this medication is teratogenic and can lead to congenital deafness if administered during pregnancy. Now on to some other unique medications, those being the fluoroquinolones, which end in floxacin. These are also pretty broad spectrum, yet also have a large side effect profile. This includes your standard GI distress as well as hepatotoxicity. More unique is that these meds can cause mental changes and increase risk for increased ICP and seizures. Photosensitivity can be severe as well, but perhaps the most unique adverse effect and an NCLEX favorite is the potential for an Achilles tendon rupture. Avoid giving to adolescent clients and advise patients to promptly report tendon pain and musculoskeletal tenderness while on this medication. A final note of consideration when giving these meds is that they are severely incompatible with other solutions. Take special precautions such as administering in separate tubing and at separate IV sites, and always check compatibility. Now for sulfonamides such as trimethoprim, sulfamethoxazole. These are also broad spectrum, commonly seen in practice in the treatment of urinary tract infections and respiratory infections. However, patients may report allergies to sulfa drugs. Be sure to check patient allergies before giving this medication. Sulfas can lead to nephrotoxicity and hepatotoxicity. If given during pregnancy, bilirubin may build up in the fetal brain and cause kernicterus. Patients should be assessed for rashes, especially for the development of Stevens-Johnson syndrome, which can develop into toxic epidermal necrolysis. Patient education should also emphasize avoiding exposure to sunlight when possible, or using high coverage clothing and SPF, as sulfas can lead to photosensitivity. Furthermore, these medications can interfere with oral contraception, and so a barrier form of birth control should be utilized in addition to oral contraceptives to prevent pregnancy. We're almost done with this section, I promise. We have 2 more drugs to review here, both being utilized in the treatment of UTIs primarily. Nitrofurantoin is a urinary tract antiseptic used for prevention and treatment of UTIs. Remember this drug by thinking how if there are nitrates in the urine, you should plan to give nitrofurantoin. There are some adverse effects to consider here. On the milder side, tooth staining may occur if given as an oral suspension, so patient education should include diluting the suspension and then rinsing the mouth afterwards. Patients also may experience some discoloration of the urine, also a non-concerning finding. More severe adverse effects include blood dyscrasias, pulmonary distress, hepatotoxicity, and peripheral neuropathy. Exercise caution with administering these drugs to patients with abnormal respiratory, renal, hepatic, or gallbladder function. Finally is the analgesic phenazopyridine, which is not an antibiotic, but is given to help relieve symptoms of UTIs. The brand name, Pyridium, can clue you into its indications as well as unique side effects. When you see pyr, think pyro, like fire. Give this medication for fiery urine, and expect fiery colored urine as an expected and non-concerning side effect. Other patient education for this medication should include that it should be taken with food to minimize GI distress, and emphasize once again that this medication does not treat the infection itself, but rather the associated symptoms. Let's review antimycobacterials, which require different types of medications in order to penetrate their unique structures. The most common diseases these are used for is tuberculosis. Isoniazid is indicated for the treatment of active and latent tuberculosis. It is not a cure for latent TB, but can prevent activation of the disease into its active state. As a monotherapy treatment for latent TB, this medication may be indicated for up to 6 to 9 months, making proper patient education to prevent non-adherence extremely important for these patients. Isoniazid is potentially hepatotoxic, so patients should receive regular monitoring of their liver function. Assess the patient for indications of liver failure. Ingesting alcohol while on this medication increases the risk for adverse effects on the liver, so the patient must avoid concurrent ingestion of alcohol-containing products. Along that note, patients should not take this medication concurrently with disulfiram. Doing so can lead to toxicity and psychosis. Another TB drug to cover is rifampin, which is often combined with other antimycobacterials in order to treat this illness effectively and to prevent resistance. Like isoniazid, hepatic toxicity is a major concern and should be assessed for closely. Unique to this medication is its potential to cause orange discoloration to the body fluids. This is a non-concerning finding, so patient education should emphasize this. GI upset is also commonly reported. Rifampin may be taken with food to decrease the severity of these uncomfortable impacts. Antiparasitic medications may be given to treat infections caused by protozoa, helminths, and ectoparasites. The first we will discuss is metronidazole, which is commonly given in the treatment of enteric illnesses as well as for prophylaxis for GI and pelvic surgeries. Adverse reactions to watch for include those that impact the CNS, such as vertigo, ataxia, and peripheral neuropathy. Report these findings to the provider as they may indicate that toxicity is present. Unpleasant but potential side effects include altered taste sensation and the harmless darkening of urine. Patient education should emphasize avoiding concurrent use with alcohol, as an intense disulfiram-like reaction may occur. Of a related note, if this medication is given with disulfiram, a psychotic reaction may occur. Another antiparasitic we will cover is chloroquine, which is indicated for the prophylaxis and treatment of malaria. Additionally, this medication may also be given in the treatment of autoimmune conditions such as rheumatoid arthritis and lupus. When given for malaria prophylaxis, the patient is instructed to take a 500 mg tablet, starting 1 to 2 weeks before traveling to the location where malaria is present. The patient should continue taking the medication up to 1 month after returning to an area where malaria is not endemic. A severe adverse effect to closely monitor for is chloroquine retinopathy, which can result in irreversible ocular damage and vision loss. Therefore, eye exams should be regularly performed, especially if given long-term, such as in patients taking it for autoimmune disorders. Now for a couple antifungals. Serious fungal infections requiring treatment are rare in healthy individuals with functional immune systems. If a patient is immunocompromised, such as if they have a diagnosis of AIDS, risk for fungal infection increases. It is important to monitor for fungal infections in these patient populations, as prompt management is required. Amphotericin B is indicated for the treatment of severe systemic fungal infections, such as candidiasis, which is infiltrated into deep tissues. One of the most commonly emphasized complications of amphotericin B is nephrotoxicity. Monitor the BUN and creatinine of these patients, and do not combine with other nephrotoxic medications. For severely ill patients, eyes and nose may be indicated to monitor for oliguria and anuria that could reflect acute kidney injury and intrarenal failure. Administration note: if this medication's PO solution is given for the treatment of oral candidiasis, instruct patients to first swish the medication around the oral cavity before swallowing. Doing so allows for maximum exposure to the affected mucous membranes. Ketoconazole is given for systemic fungal infections as well as those of the integument. Those who have used anti-dandruff shampoos may recognize this drug as one of the present ingredients. Rather than renal toxicity such as with amphotericin B, we are concerned with potential hepatotoxicity here if this medication is given systemically. Monitor the patient's baseline LFTs and compare them to LFTs obtained throughout the course of the therapy. Further assess for indications of liver failure. Something unique about ketoconazole is that it requires an acid medium for absorption if given PO. Patient education may include recommending that the patient avoids concurrent antacid use, and to take this medication with a drink such as Coca-Cola to facilitate absorption of the med. The way I remember this is thinking about keto, where ketones can make the blood more acidic. When you see keto, Think acid. The antiviral medication we will cover is acyclovir. This medication has many forms and indications, with IV usually reserved for the treatment of viral illnesses in immunocompromised patients, while topical or PO forms may be used in prophylaxis or for early treatment of viral infections such as herpes simplex virus. This medication is most effective in reducing the severity and duration of viral illnesses if taken within 48 hours of the initial onset of presentation. Patient education should emphasize staying well hydrated while on this medication to reduce side effects such as headache, vertigo, and more severely, renal toxicity. When the topical form is administered to patients with HSV, ensure that gloves are used and that the lesions are not scratched if at all possible. Make sure to doff gloves and perform hand hygiene before touching anything or anyone else to ensure that the virus does not spread when exposed to other mucous membranes or non-intact skin. Thank you for watching this quick review of infection drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.